All right. So, who's first? Melissa,
Yes, for technical reasons more than anything else.
Well, am I still frozen or
No,
what?
but actually you look good now.
Okay,
But
you're good now. Yeah, I don't
Joe. You've
know.
been. Oh, wait, Joe, do you want to go second or Mary
Well,
Grace?
Mary Grace has to go last because her case
Okay.
is Sunil's case.
Neil. So Joe second, and then
Yeah, whatever you.
Idiot.
I'm
Sorry.
fine.
Bertan and Mary Grace. I think we should do your case first, Mary Grace, just to like criticize Sunil for everything that he taught you. This is perfect.
Okay.
Where's the exalted leader?
As playoff
Neil.
game.
Yeah, it's the end of the third quarter.
Nice. Even better. Okay, here we
Shall
go.
we get
Hard being
started?
chair.
all right.
Do you want to get started?
Yeah.
Okay, I'm going to admit everybody in.
As everyone's coming in, good evening, wherever you may be. We are just waiting for a second to get everyone loaded up. I think that looks good. I guess we'll get started. Hello, everybody. This is our spring Cobra event brought to you by the retina faculties from the Cole Eye Institute and Byers Eye Institute in Palo Alto. We are excited to showcase some of the trials and tribulations and surgical exploits of our fellows and to learn from them as they're going on their journey as well. I am Prithvi. I'm here in Palo Alto, and Dr. Srivastava has a very important emergency that he is unable to be here right at the moment, but he is soon on his way. I'm sure it's something really important, so we'll wish him well for that. But we've got four amazing fellows today who will be presenting four really informative cases. And we have a stellar faculty here who will be discussing those cases with us. This does not happen without the support and enthusiasm of our friends at Bausch and Lomb. So we thank them for continuing to support these events. And we have some announcements of upcoming events, including Cobra Live at the American Academy meeting, which we'll share with you as the evening goes on. So we'll start from our side here at Stanford. Melissa Yuan is going to be presenting the first case. Melissa is one of our outstanding first-year retina fellows, joined us from Mass Eye and Ear. And take it away. Great graphics. That must have taken a long time to color
Thank you.
in.
It
That's
took me a
wonderful.
few ChatGPT prompts, I will admit, and I still ended up with
Perfect.
two light pipes, which I'm not sure what to make of that.
That's good illumination is key.
Yes, yes, exactly. This is the two light pipe technique. I am one of the first year fellows, and this is a case that I did with Dr. Pan at our county hospital. So this was a 54-year-old woman with diabetes. Her last A1C was 8.8, and she had a history of meth and cocaine use. We used to follow her for NPDR with DME, and we gave her a couple of Avastin, and then she disappeared for a year and a half. She represented with vitreous hemorrhage in both eyes. B scan at the time of representation showed areas of vitreous schisis and traction in the right eye, but no overt detachment that we noticed. The left eye had a focal TRD. We gave several Avastin in both eyes, but her right eye did not improve. Just to show you, before we lost her to follow-up, very typical appearing DME. And now her current presentation, after several Avastin in both eyes, her left eye has improved to 2300, and you can see some of this, heme and focal TRD. The right eye, there's absolutely no view, and she has light perception. Given the PSC and the heme against the posterior capsule, we decided to do a combo phaco-vit in this right eye. And I will note that B scan was not repeated immediately preoperatively. The last ultrasound we did for her was over 6 weeks prior to the surgery, and that becomes very relevant soon.
So
So that,
Melissa,
yes.
just as you're planning on your case, you mentioned the ultrasound. Like, what are you as the fellow who sometimes, you're your co-fellow has seen the patient before you, or someone else has seen the patient, and you're walking into the case. What are you trying to ask about the ultrasound? What are you trying to, garner if you did the ultrasound yourself, as you're planning these cases?
I think aside from the obvious, is the retina attached or detached? Where is it attached and detached? We want to know about the hyaloid status. It's very important in a case like this. It will really impact how we go in, and where we begin, and how, and give us an idea of, is it tightly adherent everywhere, or do we have a cone that we were able to incise? And that would have been really helpful going in instead of just going in blind. So let me get my video.
Pat, are there any other things to think about as you're combining to do a phaco vit in a diabetic where, can't see anything? What are some of your kind of like, warning signs or things that you do differently to accommodate?
Yeah, I think it's a really good point. I don't always do combo cataract surgery if I'm doing a diabetic TRD, but if there's a lot of hemorrhage, there's a significant cataract or the hemorrhage is like right up against the lens, and I'll usually do it. I always put in the ports first before turning over to the cataract surgeons to be able to do their portion, because otherwise the eye is pretty soft when I'm trying to put in my ports. And then I always ask them to close afterwards with a suture. I usually take it out at the end. But those are things I'm doing. I also, when after they do the cataract surgery, I'm more likely to do a small capsulotomy too if there's a lot of hemorrhage there to be able to clear it. But I want to be careful not to make it too big. So it's smaller than you kind of do for patients in clinic, because otherwise, obviously, the lens could fall out the back and you don't want to make your case more complicated than it needs to be.
So, Sharma, if you were doing this like a combo case and you didn't have good capsular support to put a lens in the bag and you still have to do a vit, would you leave them aphakic, or are you okay putting it in the sulcus, not knowing what you're going to find in the back and what tamponad's needed in the future?
I think it depends on the situation. If you're doing a bad TRD and you don't know what's going to be in the back, it's fine to be aphakic and come back. It's also fine to put the lens in at the end of the case, depending on how it goes. You don't have to put it in at the beginning. In fact, it's sometimes easier not to have it and then make the decision. So I think you have lots of options. I think the key is that aphakia never blinded anyone, but not fixing the retinal detachment can. And so really make sure you give yourself the best chance of that.
Yeah, I like the idea of not having to put the lens right at the time of the phaco being completed. Leaving away aphakic, putting a little Helon in the bag, and then coming back once you decide what you need to do. But if everything is going great, I don't see a problem with putting it in the bag right at the moment. All right, Melissa, show us your stuff.
Very good points. So here you can see we've already put in our ports, and I'm doing the cataract surgery now. There's no red reflex because of the heme in the back, but it actually goes totally fine. We get a one piece in the bag, put a stitch in, like Dr. Talcott mentioned. And then we go into the back and you just see this dense heme. We've cleared some here and, incising the hyaloid face there and beginning to lift it. Unclear what is happening inferior temporal, but nasal is looking safe. We get the hyaloid up a bit there. Um, and we clean it up a bit, and we're getting a better view of what's going on, although we're still not entirely sure what is happening here. We go layer by layer, start clearing things out, which is giving us a better idea of what we're dealing with here. We come inferiorly, start working on the hyaloid here as well. Um, Takes a few tries, but you can see there's some sort of subretinal hemorrhage. And it doesn't look like a typical, we get the hyaloid there, like a typical diabetic fibrovascular proliferation. It looks very strange. But we still go with our, usual principles, get the hyaloid up, and there's clearly an inferior temporal detachment that we are going to figure out what the deal is with soon. Here we are with this like thick preretinal hyaloid stuff, and we try to lift it. And as we're peeking under, we're able to see that the retina is not looking so good under there. It's looking very moth-eaten, ischemic. There's holes in it. Um, and then we come in anteriorly and you see this dense plaque thing, which we work on a little bit from the anterior side, trying to get that off as well. And that's when, you can really see the retina starting to reveal itself. There's a hole there. And we keep liberating heme as we're doing this because there's this blob of subretinal heme as well. Um, at this point, it's, the view comes in and out because of the heme, and the stuff is really stuck on, and the retina is not in great shape there. So we're trying to figure out what to do. We spent a long time
Melissa, can you
here.
pause for just a
Yes,
second here? Yeah.
absolutely. Yeah.
So Asan, you're in this position now. And are there changes in approach right now that you're going at? It looks like Melissa is trying to kind of work her way from the vitreous to the surface. Should we be changing approach at this point, or is it still a matter of kind of getting down to like filleting your way down to the surface?
First off, I'm a little concerned about the view not being so great here. So this is sometimes a opportunity to just stop, just reassess like your cornea, recode. You can do a little massage with a Q-tip, improve your view, get rid of some superficial edema. Sometimes if you did a combo case here, you can irrigate out and you'll find out there's some hyphema and red blood cells. You just wash that out and your view improves. So that'd be my first step. Um, I like to sometimes start by going into the periphery and working my way posteriorly. Sometimes you get like a pocket of vitreous that you can kind of, cut in and get access, and then you can kind of work your way from there. But yeah, I think viewing is more the most optimal issue right now.
Is the cornea hazy, Melissa, or
It
just a
wasn't
hard view?
terribly hazy. It's more that like as we cut into this stuff and heme gets liberated, all the
Mm.
particles are really getting in the way. So we spend some, if you spend time just cutting and aspirating, it did
I think
clear.
it's just when she paused, that's when there's
I
vitreous
had to
hemorrhage.
deposit
But
this
there's like,
spot.
yeah, there's
It was better
pockets, like
2 seconds
moments of
ago.
clarity,
Yes. Yeah.
intermittent moments of clarity.
The other thing that can be nice sometimes to do in these cases, and I'm sure you were doing it, is just like redirecting the infusion a little bit. You can go up to 60 for a little bit and see if you can just like liberate a bunch of that stuff and then hopefully get more of it and then things will clear up. But yeah, looks like there's just a lot of old hemorrhage there.
Mhm. All right. Yes, agree with all these points. And so we started from the posterior and trying to come anteriorly. Now we're going anteriorly, trying to come posteriorly, just trying to get this stuff off, this detached area with subretinal heme. Um, but there, like this particular plaque is really stuck. We put some Kenalog in. You can see that we did a good job with the hyaloid elsewhere. It's up, at least to the mid periphery, and we clear some of that. We work on it a little bit more nasally, infranasally, and you can see that's worsening the detachment when we pull on it because it's so adherent. But we do really need to get it up so that we spend some time doing that. Now here we are looking at this area. We, go through one of these holes and try to get some of um, that subretinal hemorrhage. But we decided at this point that there is no way we're going to get this retina flat without doing a retinectomy. And that is for several reasons, one of which was including that we were not sure if we got the hyaloid up everywhere in this area. In fact, we were pretty sure we didn't in some of these areas here. And this really adherent pre-retinal plaque, and this, subretinal heme. And so that is why we decided to do a full inferior 180 retinectomy at this point.
So if you can pause a second. So Sumit, before this decision for retinectomy, if you're seeing this kind of inferior dense, plaque, it's not coming up. What is your thoughts on scleral buckling in diabetic eyes? Do you do it often enough? Like other indications for you? If you get all the traction off, you don't need it. Or if you're looking at something like this, where it's going to be, hard to get it all the way up to the periphery. Do you think about a buckle in a diabetic, or is that
And
not
I've
required?
tended not to. Um, you don't do retinectomies that often in diabetics, but when you have to, I have not traditionally put on a buckle. I haven't found it that necessary. I think usually, you get the traction off the posterior out past the equator, and then you usually do okay because they're not usually getting those peripheral breaks and the peripheral foreshortening. And your retinectomy, as long as you make it large enough for the inferior 180, I haven't found the need to. I'm curious if others have put on buckles in these situations.
Asan, what are your thoughts?
Not, I'm typically trying to avoid intraoperative buckles. And there have always been cases where like I'm like, oh, maybe we should do a buckle here, and I have colleagues who do it, but I don't know. I tend to be in that camp. Once I've committed to something, I'm a little bit stubborn. I'm gonna go see it all the way through. So,
Catherine, are you as stubborn as Asan, or?
Well, Asan and I trained at the same place, and I think we also have some PTSD from putting on some buckles in the middle of cases. So, in my book, you get a buckle at the beginning or you don't get it during the case. I also think about like there's like three things you can do. You could do like a buckle, a vit, and a phaco. You could do a buckle vit or phaco vit, but I try and avoid all three.
Yeah, all three gets hard. Your view is going to be trouble, and unless you've like planned for it, I think it's hard. Maybe the preoperative ultrasound could have told you a little bit more. I remember in fellowship, like very peripheral, those rare cases of like very peripheral detachments, inferior. We had some of our attendings that would put buckles on those, and it's a different era gone by, but still, it did make sense in some of these where you might be cutting inferiorly and you can't get the hyaloid fully off. But again, I like Kat's point. 2 out of 3, but not all three. I've loved that. That's really good.
So what
Melissa,
would you do?
can you rewind just like a couple frames? I just want to point out like one thing that you didn't really show. So like wherever there was a white stuff that's in focus, but there was like this like pre-retinal,
Pre-retinal whites.
dehemoglobinized white
Yeah,
stuff
this
plaque.
stuff.
That
Yeah.
stuff that's intraretinal. But then the white stuff peripheral to that was dehemoglobinized subretinal hemorrhage.
Mhm.
So yeah, so that's ultimately why we decided to retinectomize, because even if we did like a focal retinectomy of just that thick plaque, and you'll see during the retinectomy part 2, the subretinal blood, it was like cottage cheese. It's coming up in clumps. And so there's no way for us to laser the anterior portion of a focal retinectomy without cutting more retina. And then I don't like doing a quad retinectomy inferiorly. And so then that's why we ultimately decided to do a 180 retinectomy on this case, which again, I don't like doing retinectomies in diabetics, but for this one, I didn't think we would be able to get laser around a retinectomy. And then what do? So we had to just cut it all out. Yeah. So I wasn't there when, I think you guys discussed it internally, but that was one of the points I wanted to bring up during this case.
It makes a lot of sense.
Yes, and that was definitely something we were talking about intra-op while we were going through all this. When we made the decision to retinectomize at this point, we all these holes here, this pre-retinal plaque here, subretinal heme up here. And so you'll see what the subretinal heme is like in just a moment. So here we are just trimming the anterior hyaloid and now eating the anterior retina there. And here is that subretinal stuff. So this particular clump, it's being very difficult. We managed to eat some of it with the cutter, but it's not really, it's very rubbery and not easy to eat with the cutter. So we give it a few good tries, like really smushing it in there. We'll come back to it. We come to this subretinal stuff there. We do some depression, get rid of some more of the anterior retina, and the heme over there. And now we'll make our way back to this thing. So this thing, we first try to grab it with the forceps and just, like you would, and bring it out. It does not make it out. The wound falls back in. We try that a couple of times and it just does not come out. So we enlarge the wound because maybe we're thinking it's getting stuck in the wound. Grab it with max grips this time. Still does not make it out. And I'm not even showing the number of attempts we did. Here's the fragmentome because we are at the Valley Hospital and we are told that there's no easy access to foreign body forceps. So we pull out the frag. And the frag doesn't even make a dent in this thing. We're smashing it in with the light pipe. Nothing, nothing at all. So we give that a good many tries as well, because at this point we're almost out of ideas and doesn't work. So it's still there. And that's when Dr. Pan comes up with the idea that we should try to lasso it with a flex loop, which some have described for IOFBs. This thing is a little bit large, so we have the flex loop deployed. Sorry for the bad lighting. And we're kind of rolling this nubbin around, trying to be very gentle because we are right over the macula here, trying to get the flex loop around it. And almost had it, but then it rolled away. And then rolling it back around the other way here, we finally get it around, tighten it a little bit, and it gets into the wound. We're able to get it out. We send that for pathology. We'll come back to that.
Nice.
Close that up. Now we put down our perfluoron, and the retina does flatten.
Can you pause it for a second?
Yes.
So that was great that you were able to get it. You can also, like Kat's saying, you can lasso it. So if you take a 20 gauge angiocath and you put a Prolene suture through it, you can use that as your lasso. And that works really well too. You don't need the flex loop and you can get it much bigger. I've used that for glass foreign bodies that wouldn't grab with the foreign body forceps even.
Mm.
And that works really well.
I just learned that technique of a buckle this like a couple weeks ago, and I said, "Oh, that would have been good to know at the
Yeah.
time." Yeah. So it came out, thank God. And I learned later that we actually do a foreign body forceps. Just the staff didn't know what they were. So here we are putting down the perfluoron, and feeling good that it's flattening. We laser along the edge of the retinectomy, um, and put PRP elsewhere. And then we drain, making sure, to stay at the edge there. Don't want any fluid sneaking in. And then we finish drying it out at the nerve. And then we put in oil. And that is the case. A much shortened version of what Dr. Pan went through with me that day. Um, so back to how did the patient do? So day one, she's already seeing much better and she is so excited. Her IOP is borderline, good fill, attached retina. She's thrilled. Week one, 2300, IOP's okay. She's fully attached, a little bit of DME there. Um, didn't get optos, unfortunately. And then she no-showed for month one because she is getting a foot ulcer taken care of. But I'm hoping she comes back soon. Um, here's the pathology of that subretinal stuff. It was choroid tissue with hemosiderin pigment deposition, which yikes. But it was, free sort of floating around already, so I guess it needed to come out because it was sort of already free. And that's the case. Thanks, Dr. Pan, for your patience and guidance in this case, and thanks everyone for your attention.
That was very nice.
So I'm just curious, what do you think that was? Do you think it was like some large, like sub, like I don't know, like subchoroidal hemorrhage, like Carolyn?
I don't think so. I think it was probably like neovascularization
Uh-huh.
that had like fibrotic component and it's extended. Like, sometimes you've seen that in diabetics too, when you have an attachment, then it bleeds inferiorly. And it was there for sometime after the first ultrasound, but before we went to surgery in
Mhm.
those like 6 weeks. That's just kind of like what happened. So it's just like some fibrotic clump. I don't know if it was choroid, but
Yeah, a bit of subretinal, and then it's, the RPE stuck to it, and then it
exactly.
contracted, and then something underneath it kind of came with it
Mhm.
as well. So yeah, it's a bunch of fibrotic crap. ASON methotrexate in this case, do you think the PVR risk is the same in a diabetic retinectomy
I'm
situation?
I do quite a bit of methotrexate, so I'd
I
say
heard that. I
I,
did. I heard
I
that.
discuss it with the patient. If they're amenable to it, I really don't see much downside to offering it. I don't know, I don't do guard style, 12 monthly injection protocol, nothing like that, but we do more like a treat and extend protocol. If the patient wants, we do it. Have had
This
good.
patient does not like intravitreal injections. That's why
So
she
no,
no-showed for a year and a
So
half.
pretty straightforward. No
Yeah.
need.
answers that one. Yep. Very good. Kat, you want to take it away for our next case?
Sure.
Joe is up.
So Joe, do you want to go next? Is that okay? So Joseph Abraham is one of our stellar second year fellows who's going to be doing labor of love, TRD, like repair with his mentor, Dr. Sasser, for the case. Thanks so much, Joe, for presenting.
Of course. My screen's sharing okay?
Yes, it looks
Perfect.
great.
I feel like Joe's been here for like 4 years.
We love him that much.
Yeah. It only feels like 4 years.
You're supposed to follow that up with a compliment, Asan, about how much we love Joe's videos.
All right, so I am going to be presenting another diabetic case here. We had a 44-year-old female presents to clinic, uncontrolled diabetic, really poor follow-up. Last A1C, all the was from about 3 years prior, and it was had been over 10 consistently on all her prior lab work. So we were planning on doing the right eye first. She said she lost vision in the left eye a long time ago and was reliant on the right eye, but then went down to count fingers recently per her, and she's not been able to function whatsoever.
So
And just a quick
the right eye
question.
is the worst eye? I'm sorry, or the left eye is the
No.
more
The
chronic.
right eye is the one that she was relying on. She said she had
Mm.
a little bit of vision that she could at least ambulate and get around her apartment. But then the vision in the right eye decreased significantly over the last few months, and that was what finally prompted her to come in because she functionally just declined. So I
Well,
think the
wait a
left eye
minute.
was
You know the
not
question I'm going to
well.
ask. So to the
High five
panel.
her.
So which eye do you do first? And Joe gave us his thought that she was more functional with this right eye, left eye chronic vision loss. Let's try to rehabilitate the maybe the more recent vision loss eye, which is the right eye. But going across here, so Carolyn, you
Yeah.
see a diabetic or two in your practice. Like this comes up all the time. Where are
Yeah.
you
So
going
for
with this?
two bad eyes, I agree. I usually go with the better eye first. Patient's happy, and then they will let me operate on the second eye if I choose to operate the second eye. Sometimes I say like you only get one surgery, and it's just the good eye because the left eye is too far gone. But yeah, better eye in this case.
Kat, like how do you tell, other than their history and maybe, if one eye is hand motion, the other one's count fingers, that's not that much of a difference of vision. Like what else are you looking at to make that decision? Which eye do
Mhm.
you go with first?
Yeah, I think the OCT can be a little helpful here. Sometimes you'll see these cases where there's just more sort of traction throughout the macula, but most of the fibrovascular plaques are like on the arcades. I think FAs can be helpful too for just looking how perfused the eyes are, because that gives you a sense of like visual potential too. I agree with Carolyn. For situations like this, I usually go with sort of the good eye. Even if you intend to do both eyes close together, I mean, inevitably they end up being at least a couple months apart by the time someone has the chance to recover. And if you put a bubble in, the bubble is sort of gone. So I usually go with the better potential eye first.
Joe, do you have any OCTs you can show us?
Glad you asked.
You've been here for 4 years. We know your next step, man.
4 incredible years, Prithvi. So this is the right eye and the left eye here. Both, macular is off, as you could clearly see on the optos. I mean, with the left eye, it looks
Yeah,
like it's
Kat,
further
Kat, does this
elevated.
help you? You wanted the OCT.
Yeah.
Like, how
I
does
think
this
they both
help
look
you?
bad. I think they both look bad.
Well, at least you can see the choroid on the
Yeah,
on
it's
the
true.
right.
The like
It's
distance
close.
is
Yeah.
closer together.
That's
The
good.
I would say that your bottom left picture kind of looks like the Golden Gate Bridge.
Yeah.
It
It does.
does. Do you
Yeah,
want to send them to
it does.
California for us to do the surgery?
Yes,
Yeah.
Carolyn Pann's a TRD expert.
That,
Do you have an
that was what
FA?
I should have done.
An
Yeah,
FA?
Kat
Yeah.
wanted an
Uh,
FA as well.
we didn't have enough. They were all seeing it satellites. So
They're
we
probably
didn't.
a
I'm gonna
hard
guess
fit.
ischemic, like very
Yeah.
ischemic.
Yeah, because I think the FA can help guide you in terms of which eye to do. Sometimes if they're super ischemic in one eye or the other, it can help you decide which one has the better visual potential.
Did you PRP the other eye, Joe, before, like in the clinic that day, or did you put PRP in this eye, the right eye, on that day? Why or why not?
We didn't PRP completely. There was a lot of shallow fluid, so uptake was really poor after one attempt, and the patient didn't tolerate it super well. So plan was to do the surgeries within a few months of each other and try to get all the laser in at that time once everything was flat.
And then did you give a preoperative Avastin?
Yes. Oh yeah. There was there are three pre-op Avastins. One of them was the week before surgery.
So, I mean, Kat, that didn't look like super, juicy and moist in terms of vascularization. Like, are there cases that you wouldn't give a pre-op Avastin if you're going to surgery pretty soon and you didn't see a lot of vessels, or is it always helpful to have some Avastin on board?
I think it's always personally helpful to have Avastin on board. I have a little PTSD from some cases where there was not pre-op Avastin on board, and I feel better about it. To be honest, though, even if it's not really beefy like it is here, I'm a big believer in doing at least a sequence of Avastins or trying to get some PRP. And the PRP helps with the countertraction during the surgery. And the other nice thing, if you're going to do a sequence of Avastins, is it just allows you to establish a better rapport with the patient. Use the opportunity to hopefully, try and get their diabetes under control, talk to them about sort of like expectations of what surgery will get you, guarded prognosis. And I think that that time, to be honest, serves you really well in the post-op period, especially for this patient who has really guarded visual prognosis, even after, a potentially successful anatomic like repair.
I'm also
So
seeing the
social
most
Avastin.
well, no, but
Social
also
Avastin times 3.
I've seen the most ischemic retinas intra-op still bleed like crazy. So just because you don't see it in clinic doesn't mean it's not going to bleed.
Fair.
There you go.
All right, Joe, take us through.
All right, so as with any TRD, the first thing we're doing is relieving the anterior posterior traction. And so we're just going around, and sometimes in these cases when you have like the hemorrhage, it makes it extra simple for the visualization piece of where you want to go with relieving here. Also trying to be mindful of any tented retina. So we're just gonna go around 360. Actually, just before I proceed, I don't know, Kat, if you remember, but there was we were on call together, and it was like a couple days before our OR day, and the afternoon we were just waiting for some RDs to come in, and I ran into this like terrible TRD, and I was like, Kat, what do you think?
And Joe's like, how about we add it for 2
Friday?
days later? And I say, no, we're not adding it for 2 days later, Joe. TRDs need a little love, a little pre-op love.
All right. So then we stain with some highlight. I know some people here are not big fans of going crazy with the triamcinolone.
Do you dilute your triessence, or are you taking it straight out?
Uh, this one looks like it was pretty, I think this was undiluted because there's some chunky
Yeah,
pieces there.
looks full strength.
Yeah.
What about
So
you? Are you
starting,
diluting or are you going straight?
2 to 1. Segmentation.
The quest.
yes, this is going to be a lot of segmentation. So first trying to, there was a opening temporally to access through the plane there. And so I was trying to carry that forward. Trying to be really careful not to induce a break, maybe overly so, in terms of like resetting my position with the cutter.
Yeah, I'm just curious, Joe, since you've been, a fellow with us for apparently 4 years and you're going to soon be out on your own, how do you decide like where to start for these cases if you're looking and you just see like a ton of like fibrovascular plaques? Like, what's your plan of attack?
So I guess I would try to find, uh, take what's available. So there was that opening temporally, and we were able to track that inwards and then create some of those spaces. I know that some people like to kind of do the en bloc dissection maneuver too. I would really try to see what the tractional membranes, how they're behaving, to kind of determine that. I feel like each eye is often a little different.
Makes a lot of sense.
So we switched to the green here. And there are a couple things in here. I'm sure people will potentially have some strong opinions about whether to do or not do, but we'll get to that later. So we're just going to continue segmenting here, and trying to get off some of the traction from the nerve.
You brought that forcep forward. Was that trying to induce a PVD more off the nerve,
That
or was
was,
that just
in this case, that was just to create a little bit of space to allow the cutter more room because I just couldn't get through into a plane there. This was a true quest to get out into the periphery here.
Are you using the 25 gauge cutter, Joe?
Yes.
Okay.
Actually, no. This is the 27.
27 gauge cutter. Asan, like what are your go-to instruments for TRDs? Do you like the 27 gauge cutter? Are you a lighted pick person?
I'm big with the 27 gauge cutter. It's one of these things you get in drop and you sort of like a frag case with a retained lens material. Like I should get the frag out, I should get the frag out, and you just keep kind of powering away with your standard instruments. I find that with these cases, you should go to bimanual sooner than you do.
Mhm.
Mm.
Temptation is just to keep pushing forward with what you're doing, and even if you get the thought that I should be bimanual, you should just do it. And I know Prithvi is going to agree with me, and it's just I always hear his voice in my head when I'm in these types of cases. The sooner you go to using two hands with whatever your second instrument is, the better it's going to be.
I was actually just thinking that I don't do bimanual very often, but this is the case where I would have done bimanual. And it's mostly because like the retina, you see all that like fluid. And so like your space is just so small, having that second instrument to help lift and really like you can get your cutter exactly where you want to be is really important.
So in this type of like, broad plaque, so you're going to go bimanual. What are your instruments? Is it always with a chandelier? Or are you going to use a pick and the cutter? What's your forceps and a cutter? What do you want?
Yeah, I like forcep and a scissor. And instead of a chandelier, if I'm assisting, I just hold the light pipe in another valve cannula so that I can point with the light pipe and almost assist the fellow while they're doing it. And I like the lighting is way better than the chandelier.
That's a good idea. Kat, do you have what's your go-to in this case for second instruments?
Yeah, I usually like, especially training with fellows, especially like first year fellows. I think the 27 gauge cutter is really nice. It's really sort of gentle. It's an instrument that people already feel comfortable with. But I think a lighted pick can sometimes be really helpful here to kind of like shimmy in the right space and kind of dissect off to the sides too. I think it's a little bit of a steeper learning curve than like the 27 gauge cutter.
With this kind of configuration, would people switch between the horizontal or vertical, or would there be one that they would be more likely to try to dissect, cut through?
I usually always use just the horizontal scissors. I very rarely use vertical scissors these days. I think the last time I used it was in fellowship 14 years ago.
Yeah, we don't have them normally stocked, and B&L makes the verticals that we have available that come into us, and so horizontal mainly for us. I think this is the type of case where I think a forcep and a scissor could do a lot of like will get you ahead really quite quickly, because it seems like there's just plaques on the vessels. If you can lift it up and put it on traction, I think you can kind of snip through a lot of that, and it'll come up in broad sheets.
So we're going to continue our segmentation here. And as I was doing this, I was even thinking, man, should I just be continuing? I'm in the right plane. Should I just continue at cutting? But I was like, I hadn't made a break yet. And I was like, I'm not going to start doing something different when it's working so far. I don't know if anyone, like when they're using the 27 or any cutter to get through these kind of fibrovascular areas, do you keep repositioning like I've been doing, or do you just go a smooth pass, trying to elevate a little bit so that you're going to avoid the retina as best you can?
You're doing a really nice job for a fourth year fellow. I mean, I think these just take time, You're showing us a
Yeah.
video really quick in a couple minutes. I think the key thing is just having the endurance to actually do this in a case when you have a bunch of other cases lined up that day. So what you're doing here is perfect.
I'm gonna confess this was our last case of the day.
Yeah, but I think Asan's point also is that as you're trying to jam that 27 cutter into that space, and you're trying to push it through, I don't think you'd be like just zipping. I mean, I think the risk of that is that you're going to then create like a lot of other trouble. I think where you start to get tied up is that you're trying to force yourself into that like very tight space in order to make space. Sometimes you have to kind of think of, should I use something else? And I liked how you took, even unimanually, you took that forcep and you're trying to create a little bit of space by lifting up a little bit. You might have to do that, and I think the point that we're trying to point is that that could have been a good use of both hands, so you're not switching back and forth, and you could be using the forcep to kind of reflect a little bit as you're trying to get in with the cutter. But I think your 27 cutter is as good as a vertical scissor. Like it's doing all the same things. Helon dissection came up. Was that something that was considered?
No, we didn't really consider using Helon in this case. I know Dr. Shrivastava likes to sometimes dissect with that as well, but haven't used it that much myself. So then,
I think that scissor pushing move could sometimes be a little risky, where you're trying to do two things at once with that
with
scissor, where
single instrument,
you're trying to
yeah.
lift it up and you're trying to cut at the same time, like throw it in the air and cut it. That's a little tricky. So just something to keep in mind. Now the view will be awesome. Look at that.
Yeah. We did let that cornea go for probably longer.
No one needs a corneal epithelium. Just gets in the way.
Yeah, it is amazing how much better it looks. Okay, so we're going to get to some parts here shortly that I wish
I
Anant was.
think Hassan's point of this is way sped up, right? And you're
Yeah,
doing
yeah,
a
yeah,
great
yeah.
job. And it's just for those watching that have not done a lot of these, don't expect these to go quickly.
No,
Just
no, no,
take
no.
your time.
Yeah, this was a long case.
These are endurance cases, man. I was serious when I said it. Like you gotta like stop, take a break, stand up sometimes, take a breath, like crank your neck out. Like these are long cases. But if you keep consistent with what you're doing, you're halfway there. You're almost there.
So I had presented this for our surgical conference, and people were uh, not in 100% agreement of this next step we took. So you can see here there are some subretinal bands in
Mhm.
the macula there. And so that was why we were discussing, should we take the ILM here? And people had mentioned that, this can lead to really significant thinning in these diabetic cases. Um, I wasn't sure, would anyone else have peeled or would have just left it given even with those bands there?
Well, you want to peel ILM to address traction from the subretinal bands?
Well, no, more so that there was some PVR occurring, and we didn't see a break yet, but we're worried there was a stretch break somewhere. So that was the thinking there to try to get ahead of any like PVR ERM.
Hmm.
But you still have
Carolyn,
all this
yeah.
other stuff going on. I just like, why peel the ILM now? If it was like a slam dunk, you know, like wolf jaw and you got it all up in like 20 minutes, because sometimes that happens. It looks terrible, but it's actually really easy surgery. Those I'm like, okay, like let's just peel the ILM too before we put the PRP in. And that way it just reduces the likelihood that this patient's gonna have more problems later on. This one, I feel like the subretinal bands in and of themselves, not too worried about yet. I feel like you still have all this pureretinal stuff you need to get rid of. The peripheral hyaloid, even though the blood was staining it, and you're like, that's a good, it gives you a good marker of where the hyaloid is. There's still hyaloid, like the posterior hyaloid is still on all that peripheral retina too. So like that's my priority, not the ILM at this moment.
Yeah, I gotta agree. But show us.
So we're taking off the ILM, using the nerve as kind of our support area. We're not gonna go too crazy with it
That's a
after.
subretinal band under the fovea.
Yep.
Mm. Is it tenting things up right now, or is it flat and
No, no, it's not really tenting things up. The elevation is from the traction elsewhere more so.
You don't have any breaks anywhere, Joe?
We couldn't yet find any breaks, but that's about to change.
Okay, then you can get that subretinal band out. That's good.
The enemy of good is
Right.
better, my friend.
So sometimes less is more, but we we were nervous about that because it was essentially subfoveal band and debating do we go for it or not, and ultimately decided to, although we went kind of further away because we were nervous about getting too close to the macula too. So did attempt was made to get that band to see if it would come, but we're kind of far away and um, quickly decide that this is not worth.
Also, why did you choose that location?
So the location was a mix of trying to uh, pick a spot where there was still something connected. If the band came easily, we were hoping it would come from there, and we just didn't want to get too close to the macula, essentially. Although it was like annoyingly inferior, we could have maybe gone in this superior spot, superior temporally, potentially, if we were really going to go after it. But
Carolyn,
looking
is there a
now,
juicier area that you would have chosen?
yeah, looking back
I
now, I would have wished we just left it.
Yeah, I probably wouldn't have gone for it, but if I was, I wouldn't have gone more supratemporal. I agree, you don't want to do too posterior, but if you are successful from that inferior retinotomy, it's going to get a lot bigger. And I don't like having big holes inferiorly.
Right. It never stays as small as you start. It'll
Yeah,
if
that's
it's
cute.
successful,
Mhm.
yeah, it gets big.
So then we went to air and were able to drain and get all our endolaser in. So
Yeah,
I don't.
so it flattened, under air, so
Yep.
those
And so
bands may
they're
not be.
Yeah, and so I didn't show the OCT, but as you might have predicted, there was significant thinning in the areas that we peeled from. But the patient was actually, even though the vision was still 2400 count fingers, she feels like she significantly regained functionality because of like she has ambulatory vision now in terms of the peripheral vision, so she's able to maneuver around, even though, centrally not fantastic. All right, thank you.
That was an exhausting but diligent case as you're going through it.
4 years.
Nice
I
job,
think,
Joe.
yeah, nice job, Joe. I think everyone agrees that this is a lot of work, and you just have to, be able to sit through it to get it done. So yeah, good decision making too. I'm not sure peeling that small amount of ILM that you did is going to suddenly cause like a ton of thinning. I'm not certain that that just wasn't maybe more atrophic retina to begin with. So something to think about. Our third presenter is Bertan Shakir, who this is only his second year of fellowship, unlike Joe, who's done 4 years apparently. So Bertan is graduating with us in a few months, and he's going to show us a really interesting case. Dr. Shakir. I don't think we're hearing you, Bertan. I don't know if you're muted. You want to unmute?
The Stanford Fellows in tech.
Seriously.
Joe, you're like only saying that because you successfully got 3 years
No,
without
that's
any IT
exactly the
problems.
case.
Yeah, I obviously need two more years of training.
Come on, Barton.
Okay, I'm sorry. Can you guys hear me now?
Yes, perfect.
Yeah.
All right, wonderful. So, okay, let's jump right into it. So this is a case I did with Dr. DeBoer on call. So this is a patient who initially presented to our retina clinic with a history of pathologic myopia for just an evaluation. During the initial assessment, she, was noted to have high pathologic myopia with degenerative changes in the right eye with an axial length of almost about 31 millimeters. And the OCT showed here myopic tractional maculopathy with vitreous schisis, myopic schisis, as well as a focal local macular detachment. So the patient at the time reported stable vision, no recent vision changes. So decision was made to observe for now, but with a close follow-up. And then the patient presented a month later, but at that visit reported that she noticed a change in vision. And what we noticed on the OCT that there was worsening, macular detachment. So the decision was made with the patient to do surgery. This is not the surgery I will talk about today. So the decision was made to do a vitrectomy with a regular ILM peel, not fovea sparing, and then with a gas. Doing the surgery, was complicated with a couple tears in the supratemporal periphery and a localized detachment, which was repaired. And then at post-op month 1, the patient, when the gas was finally gone, reported pretty poor vision, and the OCT showed a fairly large macular hole, unfortunately. And at that visit, already the discussion or the plan was made to take the patient to surgery. And during this planning phase, the patient returned back more urgently when I was on call, reporting worsening vision. And she was found to have a near complete retinal detachment with some attachment superior nasally, but with a large, previously seen large macular hole. And even though we did a thorough exam, we didn't find any peripheral breaks. This was one of the concerns. You can see supratemporally the area where the initial break was during the first case, but that looked relatively stable. So the concern was that this may be a detachment from her macular hole, and was also notable is that macular hole had kind of like this elongated appearance, which raised some concern that there may be some traction temporally, which may be causing some of the issues here. And here the OCT, which confirms this large macular hole and detachment. So our surgical plan was to do a vitrectomy, see if we can, enlarge or, do some more membrane peel if there's any traction, particularly in that temporal part of the macula, and then place an amniomembrane graft on top of the macular hole. And then we wanted to decide whether we want to do a gas or silicone oil, but we wanted to keep both options available. And now let's jump into the case, unless there's any questions here.
Thank you for showing this case. These cases are so difficult, these situations, and it's hard to know what the right thing to do is. And like hindsight's 2020. I feel like sometimes our happiest patients are the ones that we don't operate on, but you don't know that until you operate on them and something happens. So thanks for, to you and to your mentor for just being brave to show us a sequence of events, because like retina surgery, it humbles you.
100%. That's definitely what I've learned over the last 2 years. Can be very humbling. Yeah, so we did a standard 25 gauge standard three-port vitrectomy. As you can see, majority of the retina is detached. There's this area of where the previous work was done that looked pretty good to us. So on initial assessment, we didn't really see, a large break, which we missed during our exam. So we did our sclerodepressed exam. We put in some more kinolog to see if there's any hyaloid which was missed and to see if there's any additional traction, but that looked pretty good. So we put on some ICG. Only that inferior retina looked a little bit suspicious to us. Like we were wondering if there's maybe some premature PVR, which we could peel. So we tried, and a little bit of stuff came out, but not a lot. And then we, transitioned our focus back to the macula. There was a pretty broad peel that you can see. There's a little bit of green staining here nasally, which we, attempted to peel a little bit more, but we felt this is not gonna, lead to any significant success. So we abandoned that, further peeling nasally in the papillomacular bundle. And we, in that temporal area, we were a little bit concerned that there might be some, membrane still in that area. So we put in some more ICG. And then, I don't know if you saw that, I incidentally got a little bit of the edge of the fovea into my soft tip, which was not great. So careful when you try to suck fluid out of the macular hole. But that staining revealed that there actually were some more thick membranes temporally, which we were able then to peel off. As I was somewhat scared because the retina was super thin. You can see how thin the retina is there. You can see the underlying choroid through it. But thankfully that peel went well, and we were able to get most of it off. And we felt that getting this membrane off really relieved some of the tension or traction, which probably caused this macular hole to be more elongated in an oval shape. And then again, we wanted to make sure that we don't miss any peripheral breaks. There was this tiny hemorrhage over there, but no breaks seen on repeated scleral depressed exam under fluid. So then we decided to proceed with our amniotic membrane graft placement. So first we wanted to do retinotomy, um, so we could drain. And then we placed the chandelier because we wanted to have the option to have a second instrument to help manipulate the amniotic membrane graft. So put on the chandelier, and then we take a 3 by 3 millimeter graft and just get it through the port. And then, as you can see in a little bit, this is a highly myopic eye, and I have two forceps. I have one max grip forceps and one ILM forceps in my hand. And given that I have these two baskets very deep in the eye, I kept on hitting the lens, and it was really hard, to keep the focus here because I was constantly shifting and hitting my reside. And came fairly quickly to the realization that trying to unfold this and place this, like, or partially stuff this into this macula hole is not going to be successful. And then we made the decision to place PFO, and then with a plan to kind of stuff the graft under it, which was also challenging. Again, I was constantly bumping into the reset system with my basket, and was kind of difficult to do. So I decided to take down the PFO bubble a little bit to give it the ability to roll within the eye with this, with twisting the eye to one side, and then I used my soft hit instead of my forceps to gently push the graft down and then roll it over it, and that actually worked really nicely. And there you see it. I kind of rolled it over.
Bertan, since this case was done on call, I'm assuming you're at the main and not at Byers.
Yes.
So you guys didn't have access to like
Actually,
myopic
we were
forceps.
able to add it on at Byers, and it rarely happens,
Okay.
but it was during the day. She was NPO, and we're able to do
Yeah.
it at Byers.
Oh, at Byers. So do you guys
Yeah,
have myopic forceps at Byers in the
we
OR?
do. We do. Yeah.
Was there a discussion of maybe trying that so that at least the
Yeah,
ones we
we
have at
thought about it,
Valley?
and I think we were already close to getting them out and try it. I think this was
Mhm.
our last attempt just to try to roll it over with our soft tip.
Mhm.
And we knew that the team before us did also just with regular forceps and were able to reach, even though it was a hard reach. That
Mhm.
kind of told us that it's possible, but certainly not easy, like since you're operating at your max depth of the forceps. Yeah, so that worked really nicely. We're able, once you have that graft under the PFO bubble, you can actually manipulate the graft really nicely. So you can see with my um, soft tip forceps, I was able to, move it around, increase the PFO bubble to give us a little bit more flexibility, and so the graft doesn't slip out of there. And we put in, the drop-on lens, and just to give us some extra stereopsis and resolution. You can see it unfolds very nicely, and we're able to slide it right out over the macula hole.
That's nice.
Yeah, so that worked nicely, but the concern was, is it going to stay? So now we do fluid exchange training through the retinotomy. And actually, the retina flattened really nicely. And then we take on the PFO. And I had these cases before where the graft just then kind of very, very sadly just floats away. But in this case, it really, stayed firmly in place and it didn't move whatsoever. I wonder if, due to that retinotomy, that negative pressure you create by, draining the fluid, whether that kind of sucked the graft really into that hole and kept it in place. And then we close it up and we decided to put in C3F8. I don't know if anybody would have done silicone oil in this case. All right, so
The
back.
the advantage of oil is that you could have done a direct PFO to oil exchange, and some
Yeah.
people, when we're talking about the autologous retinal grafts, that was one of the things that was discussed initially. Is that to keep everything where it needed to be, you could do that direct exchange, and it wouldn't be this, uncovered, a graft element, especially if you're going to air like at some point. So that's a thought.
Yeah. Good thought. Thank you. So on post-op week 1, it was really hard to see, but the retina looked nicely attached. I saw the graft right where it needed to be. Then I had to wait until finally the visual axis cleared, so we were able to get an OCT. And we actually, I was very happy to see that the graft kind of stayed in place and sealed off that macula hole very nicely. And the retina was attached. And unfortunately, though, vision remained kind of poor. It was still counting finger vision, which we somewhat expected in this case, but was still hoping that she may improve a little bit. But so it was just a sequence of events: macular hole detachment, and then the graft in place. Now we're almost 5 months out. She was recently seen again. Graft is still in place. Retina is still attached, and this is her fundus picture. Still looks good, but patient is not extremely happy because her vision is way worse than it was before.
Mm.
I
Anatomic
think,
success.
yeah. So thank you, Dr. DeBoer was the mentor on the case, and obviously to everybody on the panel and my co-fellows, which I'm going to miss once done with fellowship.
We can always keep you a little longer.
I mean, Joe did 4 years, so you got
You
2
don't
more
you don't
years.
you don't have to say
2
goodbye. Yeah. 2 more years. Ehsan, how do you talk to patients, myopic patients with these types of scenarios? Like, what's your office conversation?
Assuming it's a re-op, I mean, always under promise, over deliver. Like, it's not going to get a great visual outcome. I don't even use AMTs. If I think a patient may need it, I'm sending them to my partner. It's just not a skill set I'm adept at or good at or even want to be good at, to be honest. I think we saw a flurry of all these new techniques to close holes over the last 3 to 5 years, and frankly, I don't think a single one of them resulted in better visual outcomes. So don't promise much. If you can get them excited about anatomic improvement, then great. Doesn't mean you can't try if the patient doesn't want to.
Anything to add to that? Encouraging and
No, I mean, these are tough situations. And I think that discussion with the patient beforehand is critical and expectation management is critical. That, hey, we're just trying to get the retina from being not losing all sight. That's your goal here. And if you get anything better than that, then they're happy. If you promise, so you're going to see better, nothing that you do is going to make them happy in this situation. So you're really doing expectation management pre-op. And I think that's probably the most critical thing.
Yeah, I think Charles was not our surgeon for the first case. So that's where there's a little bit of disadvantage. Like, you don't have the continuity. I don't know what was discussed for pre-op for the first case, but I think that's when you have that conversation is she had a subjective decline, but the visual acuity was actually not worse. She was 2150 and she was fluctuating between 2100 and 2200. But the reason you do the surgery, tell her, is like, you will then probably progress to a total RD at any time, which she did even after the first surgery. So
yeah, is this one where you need social Avastin like visits, like where you want to see them more than once, or I get it, vision's down, you need to make a decision, but like in these, if it's before the first case, a schitic or somewhat not acute myopic macular hole, are you signing them up and let's go next week, or is this one that maybe you watch for a little bit and like really reinforce that conversation?
No, I think this is definitely someone who it's worthwhile and very beneficial for all involved to see more than once because, they said they had a subjective change. You see change in the OCT, but the vision doesn't measure dramatically different. And you want to make sure that the patient really understands the risks of surgery, that they could get worse. You could go in there could be breaks when you're lifting hyaloid and they could end up worse afterwards. And those are ones where, even if I think it's reasonable to do surgery, I'll say, why don't you think about it? Come back in like 4 to 6 weeks, let me know where you're at. Like, if you want to go see someone else, I think it's a very valuable idea to get a second opinion. And I, to be honest, hope on the inside they go find someone else with more wrinkles and gray hair than I have to do their surgery, aka Peter Kaiser.
Tell them to go to Japan where they do a lot of these kind of cases.
Yeah.
To get at it over it. But honestly, I totally echo everything Kat says. Like, if you see these really scary myopic macular cases and you swear there's a hole and there's a huge change in like SRF and thickness, you can just bring them back in a month or 2 months. You will be shocked at the degree of fluctuation and variance that these images will get. It'll be surprising. Like, what the heck did you do? They didn't do anything. It just fluctuates like that. So if there has been a change in vision, like, you should just tread very cautiously before you operate, in my opinion.
Yeah, and Carolyn brings up a good point. Dr. DeBoer took this case on, being on call. That's heroic because you just don't have the opportunity of seeing what the patient's about, what their expectations are, what their personality is like, and that's challenging. And you guys did a good anatomic job, but this is just the disease, and that's the hard part.
My email to Burton was, I hate myopic maculopathy. So that was my final point.
Yeah, fair and fair. So yeah, great job, Bertan. We're looking forward to your senior send-off in a couple of months. So there we go. I think we have Mary Grace. Kat, do you want to introduce?
Yeah, sounds good. Mary Grace is going to be our last presenter for the evening. Mary Grace is one of our stellar first year fellows and is going to be presenting, I think, an interesting case that's a little different than the other ones so far. Take it away, Mary Grace.
Excellent. Thank you, Dr. Talcott, and thank you everyone for the chance to present tonight at Cobra. I'm going to share my slides here.
I'm always impressed by how much ChatGPT can produce different types of imagery. This one looks almost like fairy tale-esque.
Just three haptics, I think.
Yes, very fitting for this last talk, but perhaps not so accurate. This is an IOL case that I am looking forward to sharing, and thank you to Dr. Shrivastava for being my faculty mentor in this case and taking care of this patient with me. This patient is a 50-year-old gentleman. He has a complex history of bilateral chorioretinitis. And I think in discussing his ocular history, it's very important to talk about his left eye first, because that really emphasizes how high the stakes were for the surgery that we were performing for his right eye. His left eye, over a period of the past 20 years, had received 5 reticerts for control of his uveitis. He also had a pseudoplast graft that had been placed when he developed scleral thinning. And then, unfortunately, he subsequently developed endothelial failure and underwent a dissect. He later developed serous choroidals and a total funnel retinal detachment, which, despite surgical intervention, ultimately could not be flattened. So he has been NLP in the left eye for a number of years. His right eye is his only seen eye. He sees quite well with it. He's 20/20. Pressure is well controlled at 17, despite having ocular hypertension that was steroid induced and requiring a number of agents for control of his pressure. And his last reticert placement in this eye was more than 10 years ago. In the interim, the reticert pellet has now dislocated, and he was seeing a few floaters, but he's not particularly bothered. And he has been noted over his exam over the past few months to now have pseudophacodenesis. The IOL is unstable, thought to be related to some zonulopathy that he has developed, but he's really wanting to hold off on surgery. And he then developed a sudden drop in the vision with an associated dislocation of the IOL, at which point we began to think about moving ahead towards surgery. And it was very important to confirm that his uveitis was well controlled and that he was inactive prior to proceeding with surgery. This was an OCT that showed he had a mild ERM, but no signs of macular edema. And this was his FA prior to surgery, which showed that he had some mild peripheral changes, but no signs of leakage, and overall was well controlled. We decided to start him on 60 milligrams of oral prednisone for 1 week prior to surgery as well. And our plan was to perform a vitrectomy with an IOL exchange and to remove the reticert. So here we are for our case, and first we are marking our horizontal axis because our plan was to place a scleral sutured IOL, and for reasons that I can discuss here shortly, we ended up choosing the MX60E for our scleral sutured IOL. And we are carefully performing our conjunctival paridomy here, making sure to dissect down to bare sclera, carefully removing the Tenon's capsule that is overlying the area with the old reticert, and then placing our marks for our new sclerotomies in the pars plana and our infusion here as well. And now, as we are entering with our superior sclerotomies, we're being very careful with the alignment that we want to have for our scleral sutured IOL. And with his uveitic history, he dilates very poorly. We decided to use iris hooks here, placing them with a TB syringe in order to have a better view, especially for ultimately removing this IOL. So now we are inside of the eye, and we're very carefully trying to cut the vitreous that is surrounding our IOL here. And you can see that it was still suspended more superiorly, but it is definitely dislocated inferiorly. And with the degree of dislocation, we decided that we wouldn't be able to salvage this IOL. And as we had been considering very strongly prior to surgery, we were going to replace this with an IOL exchange. So here we have now added triamcinolone, and this is helping with our visualization of carefully removing the vitreous surrounding the IOL. And it's also helpful to see here that there is our dislocated pellet from the Retisert. So we are continuing with our peripheral shave. And here we are very carefully shaving around the area where the strut is from the initial Retisert. And we were considering removal of the strut, which we wanted to try to proceed with, given the proximity of the strut and the old sclerotomy wound for the Retisert to where we were going to be placing our IOL.
So, okay, here, pause for a second. So, I think if you were planning, if you didn't have the dislocated Retisert and you weren't replacing it, I would have just left it. And I would have shifted a little bit more with the IOL placement. But because you had the dislocated pellet, which doesn't happen anymore, that's the old design of the Retisert, and you're going to be taking it out, then yes, you have to take out the strut, you got to take out the pellet, you got to take out everything. So I think these cases can be quite challenging, especially depending on what replacement of this is of the Retisert. That sclera can be really, really challenging to close and sometimes can require a patch graft to really get it closed. I tend to not like opening that wound up more than twice or maybe 3 times max. And then after that, you don't want to get near it because it's going to be a bad news. But here, I don't think you have a choice. I think you have to. But if it was like a 4-3 up in that location, I would have actually left the strut in place and then just shifted everything, made another sclerotomy to take out the pellet. I think you're okay here.
But was the plan to replace the Retisert or was it just to remove the pellet?
The plan was only to remove the pellet and not to replace the Retisert, given how he had been well controlled from his
So yeah, so Sumit, like for me, I don't do these very often. I would have left the strut and like you said, just shifted the wounds away and then just remove the pellet through the anterior chamber because you're going to have like a wound for your IOL anyways, and left the strut because I don't want to touch that ratty looking sclera.
Yeah, I would not remove this through the anterior chamber. I've seen the cornea go pretty much every time I've seen someone do it, they get PBK within a week or 2 after, and it never recovers. And so I would never remove these through the anterior chamber. The wound that you have to make in the cornea is way bigger than you think. I mean, you end up making a 6-7 millimeter wound to get it out through the cornea. So I would not remove these through the anterior chamber. I've learned the hard way not to ever do that again.
Yeah, I've never removed a pellet before.
Yeah, I would make a new sclerotomy somewhere else rather than go through the anterior chamber if I was really worried about the wound closure. Thankfully, we don't see too many of these. These are the old Retiserts that stopped being made around 13, 14, and so you don't really see it anymore. All these have been removed.
All right. Thank you, Dr. Sharma. That was very helpful. And that was something that we were really discussing prior to this case. What would be the safest way to extricate this pellet, especially given the patient's corneal history in the other eye? So here we are evaluating our old Retisert wound, and we are revising the wound here with a super sharp, being very careful not to inadvertently cut the anchoring suture. Here we have just done a scratch wound to try to relieve the anterior portion of the loop, but maintaining the posterior portion of the loop here so that the strut did not fall back into the eye. And here we are now freeing that with the Van Ness. So our attention turned back to the dislocated Retisert pellet here, which we lifted up with a soft tip, and we pass off here to the other hand with the micro forceps. And we are actually using the IOFB forceps and trying to treat this as an IOFB here to try to remove it from the old wound.
Yes.
And then we ended up closing the old wound, healed nicely.
And you made that look a lot easier, but that if you go back and look at all those
is chuckling at the slightly percolating, closed wound there. It's just not the same as regular.
So what did you use to close that wound, Mary Grace?
We used Fight Gold. We
Okay.
used a combination of 8.0 and 7.0 Vicryl. But we have been doing a number of red asserts lately, with it being April, and have definitely seen with the revision cases how challenging it is to close these wounds well.
Yes.
And now we're trying to pass the IOL into the AC here and using a number of instruments to do that. We started with the Pinnacle, and now we're using the cyclodialysis spatula to try to elevate the lens into the AC to allow it to rest there while we create our main wound with our keratome. We had talked about the exact timing in the case when we wanted to create the wound, and we wanted to try to maintain the AC stability as long as possible and save the wound for later on in the case. So we did create a 4 mm wound here, and we also decided to cut the IOL in half to try to minimize.
Mary Grace, can you go, when you were making the wound, did you have the infusion on? Did you have it off? Like, do you have visco in the AC? Like, what did you do to prepare everything before you made your wound?
Yes, thank you for asking that. We made sure throughout this case multiple times to coat the endothelium with viscoelastic, and I edited out those portions of the case, but we were definitely being very mindful of that here before removing the IOL to try to minimize the trauma to the endothelium. We were also working together here with controlling the infusion. Dr. Srivastava had the infusion clamped at this point as I was making my wound and also while we were removing the IOL. And then turning the back on.
Yeah, having a good assistant for these cases is really critical. And I think, especially for those second-year fellows, now's the time to start paying attention to while you're doing these IOL cases with people, like what your attending is helping you with, because pretty soon you're going to have to instructing someone else, like when to turn the infusion on and off, and like what instruments to kind of get ready to have available, because there's a lot of sequence of events that happens in a short period of time for these. And you don't realize how lovely your attendings are until you don't have them.
Very true. Yes. Very helpful to think about that now. And once we had successfully cut the IOL, we were also trying to remove some of these other pieces with it. And then we got back to work with placing our scleral sutured IOL. We'd chosen the MX60 instead of the Acryos because of the potential higher risk with Acryos for more opacification of the IOL. And we were really trying to minimize any additional surgeries that this patient would need. And
So Kat, you really pause it for a second. Kat, you really like the MX60. What are some pearls in terms of suture placement so that you don't get tilt, and then putting the IOL in the eye, and just kind of how do you walk the fellows through this?
Yeah, I mean, I think for any IOL case you're doing, but especially if you're doing the MX60 versus something like an AO60, you have to have like a system and just be like hyper vigilant of where the lens is relative to the Gore-Tex sutures, because the minute it starts to tilt, you're just going to end up with problems. So you always want to make sure that you put the Gore-Tex in correctly so that you're sort of above the haptic. And as you're doing this first step here, this is the most important, where you really want to make sure that as you're dunking the lens into the eye, you want to make sure that you have tension on those externalized Gore-Tex, so that you always make sure that those Gore-Tex stay above the haptic and the optic. And then when you're doing the other side, you just really want to make sure you have good like visualization. So iris hook's a great idea here. And then before you're finished, you want to make sure that you confirm placement, because the minute things start to twist and you can't see is when you can end up in a bad place.
Thank you. And Dr. Srivastava was maintaining tension for me with these Gore-Tex sutures that are more nasal while we were getting ready to place the folded IOL here in the eye. And we had decided with this being a right eye that we wanted to place the nasal sutures first, because those would be the most challenging for us ergonomically.
Carolyn, is as the assistant, was the line pinched or open when she was going in with the IOL for you?
For me, or in this case? In this case, it looked like the IOL was off.
How do you do it?
How do you
Oh,
do it? So
how do I do it?
if you were controlling the line there when she was putting it in, what would you be doing? Would it be pinched or would you be open?
Yeah, it would be on and up until the wound is gaping, and then I would pinch it. I don't like having fluid gushing out, but
Agreed.
yeah, I have it formed until right before she goes in.
Right. And it's a pinch, not like a, snap at the line because you need to be able to get it back on really, really quickly.
Mhm.
And we were being very careful here in assessing how our IOL was centered and using the light reflex to help with that. And we were happy with how it appeared, and we closed our corneal wounds and we sutured the sclerotomy, superior sclerotomy site here as well before closing conj and then doing our subconj.
Yeah, I think this is a good point to be aware of, just the centration. The optic for the MX60 is smaller than an AO60. So, you just want to make sure that it's not too off to one side or the other. But then I think we really focus on having it perfectly centered. And the thing that I've learned is that the eye is actually a little forgiving with it, right? Because when we're looking at these and people are dilated, if it's not perfectly centered, we're like, oh, and it's not centered. But like people really just use a little bit of it, So that's just things to keep in mind. I always find that when I'm tying I usually do like one knot on either side, and then I go back and I lock them in place by doing an extra like 2 knots on each side. I find that as I do my first knot, I tend to pull it down a little bit. So I actually usually have the lens a little bit off to the side of where I'm going to do my first one, and then it ends up being shifted just to the center. But those are things you'll kind of figure out with time, knowing your like surgeon factor and how you tend to do things.
Any pearls on how you control the tension so that the suture doesn't cheese wire through that eyelet?
You want to make sure for the MX60s, because you can pull, the lens is soft, you can pull through the eyelet pretty easily. So you want to have it much looser than you sort of think. So what I'll do is like I'll do 3-1-1 on either side. So we do the 3. And then as you're doing the second one, that's the one that's going to like lock it into position. I will actually sort of tie the second knot, and then I'll always take the like tires away from the fellows, and I almost like loosen it. So I like it at like super loose. And then when they tie the last one, then it'll kind of end up just right. But you want it to feel like it's almost like too loose. Like we're so used to just like tying perpendicular to where your suture is to like crank it in place, and that is like the exact opposite of what you want to do. So that's kind of what I do. And the other thing is I always make sure the infusion is open when you're tying, because if you have it closed and the eye is soft, then it'll end up too tight when you open up the infusion.
That sounds so non-reproducible, like meaning like it sounds like a great way you're describing it, but I hear exactly what you're saying, and I think like the risk is laying it down too tight. Asan, any other thoughts that you can add to that?
As we've mentioned many times here, we trained at the same place, we get the same guidance. I mean, the only things I'd emphasize, just don't futz around with the eyelets with any instrumentation at all. You shouldn't take, like especially fellows with the Acros who are always letting you mess around when you're threading the Gore-Tex. You should not be introducing any instrument into any eyelet with the MX60. That's a big reason, I'm in the Acros camp, just because it's, generally speaking, it's I hate to say it's fellow proof, right? It's like you guys can mess around with it, decenter it. It's just a very, very forgiving lens outside of the, the hydrophobic issue. So
How'd your patient do, Mary Grace?
We saw the patient last for post-op week 1. He was doing well. Vision was 20/40 at that point. The IOL looks centered on exam, and we look forward to seeing how he does going forward.
Nice job.
Nicely
Yeah,
done.
multiple steps. That was not easy. Good job.
And thank you to all of our Cobra faculty, all of our faculty at Cole, and all of my co-fellows for all of the learning this year. It's been great.
Fantastic. More to go. Char, can you put up the slides for us? Mary Grace, we're going to have you unshare. So we just wanted to invite you all to our last Cobra of this academic year. So Monday, June 8th. It's our senior fellow send-off. So